¿Dónde está? $17 cm, riñón. Oh. Hello. So, hello everybody, welcome back. So, today we have interesting case, and I would like to discuss a little bit how to deal with this kind of lesions now in 2021. So we have ¿cuántos años tiene la señora? 65 years old woman with a history of abdominal pain and lose weight loss. So this patient doesn't have a history of pancreatitis, but I see here a lot of microstones, microlithiasis. I don't know how to say in English that. Microlithiasis. Look here. You see? So, regarding the records of the patient, this is not a patient that we have in our hospital, was sending from another hospital. So, this is the gallbladder, a lot of stones and microstones, microlithiasis. My good friend here, Dr. Das, help me with my English now. It's not so good, my English, huh? No, it's not good. It's okay. So it's very important to evaluate everything because we don't have any record that this patient has been diagnosed as acute pancreatitis. So when we have a cystic lesion, we need to evaluate a lot of things. So first, evaluate the biliary tract, evaluate very well the pancreas. You see now, this is a common bile duct and a lot of microstone, microlithiasis. Look here. So probably this patient was not that so easy to have access to big centers or hospitals where they can be evaluated very well. So I am trying to looking for a lot of other parameters that can help me to have a diagnosis using just the B mode in ultrasound. You see a lot of microlithiasis. So My first diagnosis, in spite that we don't have that we don't have diagnosis of acute pancreatitis in this patient from the beginning. I believe that probably this could be a pseudocyst, because the clinical history of the patient, abdominal pain, but with amylase and lipase that were normal. But these were normal when she arrived to the hospital. Probably she had a pancreatitis, and then the evolution was not so good. So she went to the hospital because she had um, pain. So now, so I see also here a cyst. This is a cystic lesion, huh? Let me see. Yeah. So she have also a cystic lesion in the liver. This is what I see. This is not worry for myself. There's a big cystic lesion there. And now I am looking for in the body of the pancreas. So I coming back here. One of the way to find it is following the aorta. You see here. I following my aorta. I see my celiac trunk. I see my splenic vessels. That are here. And this is my body of the pancreas. And I believe that this is a cystic lesion. This one. Hmm? Big one. So this is a macrocystic lesion. ¿Cuánto medía? ¿Cuánto? So there is a lot of septums inside. You see here? And one of the big challenge of these lesions in the B mode nowadays is that these lesions, when are macrocystic, are very difficult to have a final diagnosis just by the B mode. And it's coming from the body of the pancreas. So with this characteristic, I don't believe that this is a pseudocyst, because there is a lot of walls inside. However, this patient had a pain, and she needs a treatment of the biliary tract also. She needs to have cholecystectomy in spite of this. So what are the probabilities? And it is very important to evaluate a lot of aspects inside the cystic lesion. Okay, so I will increase my image. So we see inside some of these, um, how I can describe this in English. So this is not a black area or complete black area like normally we can see in serous cystoadenoma. So part of the differential diagnosis is serous cystoadenoma, but also mucinous can have sometimes this kind of characteristics, and this could be probably mucus. So we will see very well here. This is not anechoic cyst inside. So I need to evaluate better this lesion to have a good diagnosis for this patient, and also to have a better decision what we need to do regarding the treatment of this patient. So I propose for today to evaluate this lesion using confocal endomicroscopy through the needle, and then to take some biopsies from using the Murray biopsy forceps. So now I will use a 19-gauge needle. Very important to evaluate if there is any vessel. So what I see is that not a lot of vascularity. That's good. So I need to go inside one of these cysts and evaluate the wall. Very interesting lesion. So you have any question, please send your questions during the live transmission. What happened?
Can you show the wall of the cyst? Can you show the wall of the cyst?
I don't understand.
La,
La pared, ¿qué pasa?
can you outline the wall? Can you point out the wall?
¿Cómo point out?
Show us the wall.
Ah, show us. The wall of the whole cyst?
Yeah. It looks thick.
Yeah, it's thick. So this is the cyst. You see? And there is a lot of thick septum. Yes. Septs. So I am using a Pentax scope J10 series, and my idea is to go inside one of these cysts. So you can go slowly. I am using I am inside. You see? I am using a spec needle, 19-gauge needle. We need to use fluorescein also. No tengo retorno. ¿Ya le pasaron la fluoresceína? No. No veo nada. No veo nada. ¿Puedes limpiar la sonda, Clever? Tienes que limpiarla acá afuera. Eso está sucio. Ok. Sí, ya salió. No. I cannot see nothing, ¿no? I can see nothing. Precárgala. I will try to go in another part of the cyst. Vamos a ver el contenido. Ah, es sangre. Ok. Ok. So it's a very rare lesion, huh? I pass directly, like I don't have this septs. So again, I don't see nothing, no? Nothing, nothing. Any kind of visualization. Very heterogeneous. And I believe that this is okay. Now I am in a wall, probably. Let's go to see here. We don't see anything. Any characteristic. So so this is a very rare lesion. I don't see nothing. It's like these are false septs. You see now. Now the wall of the cyst, but I can't traverse the whole cyst without pass any lesion, any sept. So so probably this is a pseudocyst. One because I don't see any vascularization. Okay. So because second, because of the history of the patient. And third, because confocal doesn't show me nothing. This is the wall is without vascularity. So to my opinion, this is a pseudocyst. Very interesting case. Interesting because the appearance at B mode on US can be confused. But I believe that today we have a very nice message. The first is to evaluate everything. In spite of this patient has been sending as a pancreatic mass in theory. So we saw a lot of microlithiasis in the biliary tract, and then a history of abdominal pain. Okay, well, I will finish. I will take also one biopsy, just for security, and I will do an aspiration also to send to evaluate. Quiero la Murray. Look. Luz. Luz. Look. So this is a pseudocyst. This is not blood. This is the continue, yeah, liquefaction. So now we will change of our treatment, and we will do a drainage. So look here. This is not blood. This is just liquidification. That's why we don't have any kind of view at the confocal. But this is a very interesting lesion because we were thinking about at the beginning from pseudocyst because of the history, but because of the characteristic at US, we change a little bit or abre. We change a little bit our differential diagnosis. Cierra. Abre. Cierra. Abre. Cierra. Abre. Sí, sí tiene. Perfecto. So now I will do a drainage. And it's incredible. That's why these that will appear septums are not septums. No, are not real septs. Dame una guía. Una guía. So I will pass a guide wire to use my axios, and we will do a drainage for this lesion. Uh, 15 millimeters. So I will use a 15 millimeters axios. We will send the liquid to evaluate, but normally this need to come with amylase, increased amylase and lipase, and a lot of white blood cells. Okay. Empuja. This patient needs an ERCP to clean the biliary tract. So the final diagnosis, this is a pseudocyst secondary to acute pancreatitis due to microlithiasis in the biliary tract. So we need to clean the biliary tract now. So that's the big problem of the macrocystic lesion. So that's why the patient have pain, huh? It's because of this. So now the axis is delivery. You can see this part is inside the cystic lesion, the pseudocyst, and this part is in the stomach. Very well. So I will change. I will use a gastroscope now. Necesito la imagen endoscópica, ¿no? Look, this is the continue of the liquid inside. It's raining very well. So we will test the axios during 15 days, and then we will reevaluate if the pseudocyst disappear completely, and then we will remove it. So I will close my transmission. Very interesting case today. So I would like to invite you to join us next week in DDW during our oral lectures about artificial intelligence in cholangioscopy and endoscopic ultrasound, and also a lot of new research regarding drainage of biliary tract using axios, and more and more. So thank you so much, and don't forget to join us during Endoscopy on Air on June 4. Thank you.